Infective endocarditis is a microbial infection of the heart valves or the mural endocardium that leads to the formation of vegetations composed of thrombotic debris and organisms often associated with the destruction of underlying tissues. So in this definition, this is taken from Robbins' pathology, and we can see that it is a infective process. Microbial infection, any microbe can cause it. Many microbes can cause it actually. It is the infection of heart valves or the endocardium. And in this case, we're going to form vegetations on the valves or on the endocardium that will be composed of thrombotic debris and the organism that have caused the endocarditis or others as well. And this will often be associated with the destruction of the tissue that is underneath that vegetation. So that was quite easy to understand. Now coming to the microbial causes of infective endocarditis, first of all, we need to know that the most common cause of infective endocarditis are extracellular bacteria. These bacteria are going to include Strep viridans, which is the most common cause of infective endocarditis, but it is a low virulence organism and it is going to affect only the valves which have been previously damaged. Now this previous damage can occur from rheumatic heart disease or any sort of problem actually. Secondly, we have Staph aureus, which is responsible in 10 to 20% of the cases. It is a highly virulent organism and it can damage even healthy valves. Next, we have Strep bovis, which is going to affect patients with underlying colorectal carcinoma. Enterococci and Hayseck group are another causative agent. Hayseck group includes Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. Next, fungi, Rickettsia, Chlamydia, gram-negative bacilli, and 10% cases are also culture negative. That means that when you do the blood culture, it will come off as negative. Now the fact that this culture is negative, that can be because of antibiotic therapy, because of difficulty in isolating the agent, or because the organisms will be deeply located in the vegetation. So it will not be readily released into the blood, and because you're doing blood culture, that will not be evident from that. Now we have many predisposing factors which will pave the way for infective endocarditis. What these predisposing factors do is that they seed the blood with microbes, that is, they will form a way for microbes to enter the blood. First of all, we can have an infection elsewhere in the body. Secondly, we can have a dental or surgical procedure which will cause transient entry of bacteria into the blood. We can have IV drug abusers who will inject maybe dirty needles, and that can introduce bacteria into the blood. And since that is intravenous drug abuse, and the venous blood first of all comes into the right atria, so the tricuspid valve will be the most commonly affected. Next, we can get bacteria from the gut or the oral cavity, and also trivial injuries throughout the body. Now we have two types of endocarditis actually. One is acute and the other is subacute. The acute endocarditis is caused by a highly virulent organism which will attack healthy valves, as we have discussed before, and in this case we can have substantial mortality and morbidity even with appropriate antibiotic therapy or surgery. While secondly, in subacute endocarditis, this is a slow process, and in this case the organism which will cause it will have low virulence, and it is always going to affect a previously damaged or diseased or scarred valve. So and in this case the patient will recover after appropriate antibiotic therapy. And one way to distinguish between these two is that the acute endocarditis lesions will not have any granulation tissue, but in subacute endocarditis we will see granulation tissue at their bases, the vegetations that are growing on the valves or in the endocardium, and that will show that healing is taking place. So that is one point that can help differentiate between the two. So morphologically, what happens is that the vegetations that are growing on the valves either or on the endocardium are going to be friable. That is, they can be broken down easily. They'll be bulky, and these vegetations are potentially destructive. Okay, so because they can invade the underlying endocardium or valve and cause inflammation and then subsequently fibrosis, etc. But what they contain is inflammatory cells and microorganisms that are responsible for the vegetation to develop in the first place. Most commonly, the aortic and mitral valves are affected, but as I said before, that in IV drug abuse, most commonly tricuspid is affected because that's the first valve that the venous blood sees. And these vegetations that are present on the endocardium or the valve can erode the surface that is underneath it and cause abscess formation, which is called a ring abscess. These vegetations can also shed and form emboli, and what happens is that these emboli can go and get stuck in end arteries or anywhere, causing septic infarcts, because the tissue that is going to die is also going to be septic because of the microorganisms that are present in the vegetations that have been dislodged and then causes infarct in some other area. Now similarly, these emboli can get stuck and cause inflammation in the arterial wall. In the arterial wall, when they cause inflammation, they can weaken the wall and cause ballooning of the vessel wall, leading to the formation of aneurysms, and these aneurysms will be known as mycotic aneurysms. Okay. The clinical features of infective endocarditis includes fever most commonly. This is the most consistent sign in the acute form because we have bacteremia in that case. But in the subacute form, either we do not have bacteremia because that is more chronic and slow process, or the microorganisms are very deeply situated in the vegetation, so they do not actually go into the blood that often, so we can detect them, or the body can detect them and cause fever. Secondly, we can have murmurs because of course these lesions are going to be present on the valves, and if they can cause acute problems or chronic problems depending upon what they're doing to the valve. And we know that when there are valve problems, we get to hear murmurs on auscultation. Now, one important thing that we mentioned before is that one complication of these vegetations is that they will dislodge from there and go and form microemboli and get stuck elsewhere in the body. So we have 4 characteristic signs for infective endocarditis, which is Janeway lesions. Janeway lesions are actually, these are erythematous, non-tender lesions on palms and soles. Secondly, we have tender lesions on the fingers and toes. These are called Osler's nodes. We have splinter hemorrhages, which are hemorrhages in the nail beds. And lastly, we have Roth spots, which are hemorrhages in the retina. So these 4 characteristic signs are due to microemboli dislodging. In the lab findings, we will find signs for anemia of chronic disease. This will be discussed in detail in the RBC pathology. The diagnosis of infective endocarditis is confirmed by a positive blood culture for the causative organism. We can also do it by a transesophageal echocardiogram, and also, as I said before, anemia of chronic disease. Regarding the complications of infective endocarditis, because it is an infectious process, the immune system is going to react, and antigen-antibody complex can get trapped in the glomeruli, and that will cause glomerulonephritis. So in that case, we can have hematuria, that is blood in the urine, albumin in the urine, and ultimately renal failure. Glomerulonephritis is the most important complication of infective endocarditis. Now lastly, before ending the topic, let's see some causes of non-infected vegetations on the endocardium or the valves. So first of all, we have non-bacterial thrombotic endocarditis. So the name states that it is not going to include bacteria. It is thrombotic and it is inflammation of the endocardium. So It is deposition of sterile thrombi on cardiac valves due to a hypercoagulable state. Hypercoagulable state is that state in which the blood is prone to develop thrombi on its own. So it is easy for the blood to form clots inside it. That will occur due to chronic DIC, hyperestrogenic states. These are all hypercoagulable states, or also in case of carcinomas such as adenocarcinomas, in which we have increased amounts of circulating mucin, which also makes the blood hypercoagulable. So in this case, if we have hypercoagulable states, we are going to have increased formation of thrombi, and these thrombi are going to go around in the blood and get stuck and deposited on the valves or in the endocardium, and start an inflammatory process. So these are going to be sterile. This is not an infective process. Now, one thing to remember is that these lesions are not destructive as compared to those vegetations which were caused by bacteria and other microbial agents. These are going to be small, and generally for these lesions to occur, valvular damage is not a prerequisite, as we discussed previously in subacute endocarditis. The real problem in this case is not damage to the endocardium or something. The real problem is the formation of emboli, because these vegetations are actually thrombi and they can embolize. And secondly, these can serve as a potential nidus for infective endocarditis. So if a circulating bacteria sees this lesion, he'll be very happy to find it, because it will be a ready-made home for it to proliferate and convert this non-bacterial endocarditis into infective endocarditis. So lastly, we have the endocarditis that occurs in systemic lupus erythematosus, which is an autoimmune disorder. This endocarditis is also known as Liebman-Sachs endocarditis. In this case, we have sterile vegetations, no microbes, on the valves of patients with SLE in 10% of the patients. In this case, the etiology is immune complex deposition, and thus it will lead to inflammation and fibrinoid necrosis, fibrosis, and serious deformities of walls. These deformities are going to resemble the lesions which are present in chronic rheumatic heart disease. This is also an autoimmune process. Similar lesions can occur in antiphospholipid antibody syndrome. Now, in this case, the body is going to produce antiphospholipid antibodies, which will attack the endocardial cell membranes and thus pave the way for clot formation. That's all about infective endocarditis.